in the YouTube. I will put the link here. Wait a bit. Get this link. It's everything is in it. So can you all still see the shared screen?
Yeah, we can see.
Which okay, you can see the checking feed, no? Is that the slide you are seeing?
Yeah, we can see that slide.
Okay. So just to check, what are you seeing now?
Footcare advices for
Good
diabetes.
kid access.
All right. Okay. Fine. Fine. Okay. Just okay. Right. So now this is what I propose for you to advise. Uh, the the first thing is we should advise patients to how to prepare for their foot exam. So this should be a routine thing. So they have to dedicate a fixed time every day for foot examination, and they should keep a diary. So I mean, diary should comprise of each page should comprise of right and left. They have to compare the same places in both feet. There any problem, even in comparison, they should come back to us. So, and the other thing is how to wash and clean feet. They should wash and clean the feet with lukewarm water. The warmth of the water should be checked with their hands. Hands are less affected with diabetic neuropathy. Otherwise, they might get a burn. So, lukewarm water, and then they should use a white cloth or a white towel to uh, stamp on and dry their feet. They should never try foot on foot uh, to and roll around the towel and try to dry their feet, because that again might give rise to a scratch. So better to use the hands. So why a white cloth is if there is a cut or a blister or anything that is that has ruptured or say tiny laceration or something, that that will give whatever effluent that makes, it will be apparent on that white cloth. So they have to check the cloth as well. The end. So then they should have a well lit place, and they should find some help or use a mirror. Uh, if they cannot do it themselves, just turning the foot around. Some of these people are obese and all, and some of them have arthritis, and these are old people. I mean, they cannot basically do it. Most of them. Uh, so these are the uh, areas that I propose. This is how to go. This is the method I propose. Uh, heel first, mid foot, then forefoot, then in between the toes, and the toes themselves, front and back both, the nails basically. So is that clear? So then it's very easy to record and compare all that. So this is from something that we have produced in Nirogi project. You can see the same advices are there. So what they have to do is just after cleaning, feel for bumps or temperature changes uh, in the dorsum and the other side as well. And so this is basically what to do, but it doesn't actually give where to do, where to look for at what time. I mean, there are no such system as such. So basically, a lot of they are just advising what to look for, like. So they have to look for in each section scratches, uh, cracks, blisters, bumps, any color changes, redness, blueness, whatever, callosities, and in between the toes, there can be fungal infections and all. And in the nails, you can just give a push and see whether anything is coming, if there any pain, pus, fungal infections again in the toes, all that. So, and the dryness, all that should be appreciated. The next piece of advice is how to cut the toenails. I guess you all know this, and have you all come across these things earlier?
Yes.
Okay, then that's good. So cut it across, just ask them to cut it across and don't pile it. And it a little bit should remain to protect the front of the door. And when you are moisturizing, when you're advising on moisturizing, they can even use coconut oil, doesn't matter. But remember to tell them not to apply anything oily or any cream in between the toes. So that will give rise to fungal infections later. So no cream in between the toes, but powder, talc powder will do in between toes. So then we go on to advice on footwear actually. So this is a different topic altogether. Can do a 1 hour or maybe 2 hour lecture on this alone. But just to you should just grasp that the kinetic chain is there, always operational in your body. Any change in your foot, ankle, or any other bone can give rise to even headache at the top of the spine. So each and every movement will be balanced in this kinetic chain by uh, uh, adjustments from other bones and ligaments and all that. So this is what I was talking about. Say, collapsed arch will give rise to so many deformities, not deformities, so many corrections along the spine, and probably we might end up with spasms, muscle spasms, and all that. So that's why to correct, this is what we are going to correct. By we are going to correct the abnormal pressure point as well as correct the kinetic chain as well. So we have to know a little bit of fluid mechanics for this. But anyway, just to this is just a general lecture, general idea. So just remember that this thing is there. If you do any changes into the foot, the kinetic chain will be deranged. So that will cause various other problems, long-term problems. Might even end up with a knee replacement later, or get a chronic headache, backache, and all that. So footwear, but don't worry about advising on footwear. Just do it. So this is a little bit about footwear. Forget about the kinetic chain. I just put it there that to introduce the concept. So any questions on this? Okay, so why do we need special shoes for diabetics? Well, because again, as we mentioned earlier, neuropathy, foot deformities, and these should be mitigated. The foot should be covered always. That's why we need shoes, and foot deformities should be accommodated. That's why custom shoes and the pad migration. The shock absorption and all that is gone. So that has to be that must be incorporated into that aspect of shock absorption should be there in the shoe. So all these things will lead to wounding. So prevention is only by the shoe. So if we do it properly, this is what would happen. Now this is a actually the under this tab, these are all real life pictures of my patients. So you can see all these are pressure ulcers. So just maintaining them dry and offloading. So this is the ultimate result. The treatment was an offloading shoe. So not you see that scientific wound care is cheap. You need 10,000 rupee dressings. So this is again for general knowledge. These are the parts of a shoe. You should be this is just to identify that the heel counter is important to us. It will give some strength to the ankle joint, and midsole is important because sometimes we'll have to do some corrections on the midsole. Outer sole should be tough, and ankle collar, if it's there, it's good, and it should be soft. Insole is very important. That is where most of the corrections happen. And then this is a sort of a typical diabetic shoe. It should have a high and wide toe box. So you should advise on the toe box, a high and a wide toe box. And a tough heel counter that will give some strength to the ankle joint, because ankle joints instability is a non-thing in the diabetics because of neuropathy, and it is giving rise to a lot of derangements in how the food transmits body weight. So at the end of the day, callosities and wounds. So, and outer soles, as I said earlier, tough, lightweight outer soles, and adjustable. It should be adjustable. Velcro, otherwise it should be adjustable. The straps should be adjustable. More straps are better, and inner surface must be padded because they can give rise to shoe cuts, because our patient's skins is very thin because of neuropathy and all that. And the typical diabetic shoe should have extra depth for accommodating the insole that we are going to most probably we are going to do a customized insole. By the way, in the Colombo Medical Faculty, we have a clinic that runs on every other Wednesday, every second and fourth Wednesday of the month, in the 13th floor of the UCFM tower, for foot shoe corrections. So we assess and give customized insoles. So this I spoke about.
Can we refer patients? Sorry to interrupt. Can we refer
Yeah.
patients from outside for that clinic, sir?
Yeah, the thing
Oh.
is now, this is the clinic is basically it's funded by myself and Tushan. So our capacity that right now it's limited, but there's a program called Steps, who are actually doing a fundraising. Right now, they are going from Pedro State to down the Precourt Trail. They are going down the Precourt Trail for funds. So we are hoping that they will provide us with something. Then only we can grow. You can actually, you can refer, but the dates will be a little longer right now. But probably in about 3 months, we'll be able to accommodate about 20 maybe per day. And we are planning to run every Wednesday also. So then that will be a significant, we can do a significant amount of patients. Of course, you can refer, no problem, you can refer, but the only thing is it will take some time.
So if you're referring, who should I be? Should I refer to you, sir?
Yeah, at the say when the last day, I think there's a lecture from Tushan. So we'll discuss the way. I mean, we both have to discuss how to entertain a lot of patients. If you start referring, we'll have to do the services as well. So at the
Yes,
moment,
sir.
what we are doing is we are trying to minimize. I mean, even our private patients are not sent there. We are getting some patients from the really needy patients from the government hospital. So
Right.
I mean, there are private patients. So let's devise a thing. We'll let you know at the end of the course. So maybe next week.
Thank you, sir. Thank you very
Okay,
much.
thank you. So, yeah. So so this is a little bit about the shoes. I think most of the important things I actually discussed. So this is something important, that what not to buy. You should advise on what not to do. Like high heel shoes are bad, and slip-on loafers, Bata, the Sri Lankan national footwear, that is also bad. So sandals that have steps in between the toes. So these are people can't feel, so they will give trouble in between the toes. And they should get do a proper assessment of their shoe size and get the correct size always. And always ask them to don't just buy. Don't just tell that I need a size 11 shoe and buy. Just put that on, walk around the store for a little bit, and see whether they are comfortable in it and they are confident in walking. Confidence in walking also matters. So it's about primary care. If you are interested in, now basically everybody is practicing in the primary care setting this thing. So if there any problem actually, if you cannot resolve it, you should refer. The referral should not be ego challenging. That's what I wanted to just to say here. And if you are the primary person, say you are the family physician, and if the patients are coming always to you, so you should act as the hub. You should get you refer and get the referral or testing back. So that's the way to manage diabetic foot ulcer. Or any other wound for that matter. So a little bit about health education and promotion. So you should use every opportunity to promote health. And it's just a matter of knowing what you want to say and say. And you can use any innovative way that is possible. And just little something to think about is you have to put on their shoes. So you cannot advise, say, if a patient is selling lottery tickets and he or she is always standing in this thing, you cannot ask that person to not to be seated, don't put weight and all that. So you have to find some other way. So you have to have a very well articulated answer to that particular patient. That's why all that history taking, examination, and mostly the history taking should go into depths in social, economical, and all that history. So little something about wet sores. Wet sores is another about 1.5 hour, 2 hour lecture. So wet sores occur because the balance of protection and healing is gone. And wet sores are actually ischemic wounds. Do you appreciate that? Anybody? So everybody is sleeping. Anyway,
Tusi sir, there are some questions from you from the chat box too.
yeah. How can diabetic patients treat and prevent the common complaint of burning sensation in their feet? Yeah, the main thing is get their sugars controlled. Then most of it will go. And the other thing is there are urea containing creams, and there are various other components added to these specialized diabetic foot creams are there, they will give a sort of a counter sensation, and then eventually this will go off. This is part of neuropathy, and you can use a little bit of the gabapentin also. Gabapentin, and now these people are a little bit anxious as well. You can use a small dose of anxiolytic probably in the night as well. So eventually it will slowly fizzle out. The most important thing is to get the diabetes control.
Yeah, to add to that, Tusita, yeah, you very correctly mentioned control the sugar, but for the burning sensation, the drug of choice is duloxetine. You can,
Yeah,
you can add duloxetine, and it's very good, you know.
Yeah, duloxetine, depending on the severity, you can add about 30 or 60. So that basically the endocrinologist and all that uses a lot, but in my practice, I very rarely use it because of the I actually don't know how the cost is, but people are really happy with gabapentin. Only problem with gabapentin use a little bit of a imbalance and maybe a little bit of a divergent sensation. Some, especially the elderly patients. But duloxetine is definitely a good drug. Yes. Thank you, Professor Madhi, for that, for reminding me that. So, so on now, we were talking about bed sores being ischemic ulcers. So what happens is actually that picture. Anyway, what happens is when the patient is lying on the same position, especially the skin and muscle on bony prominences. The bony prominences transmit body weight to the bed surface, and the in between tissues get crushed on the body prominence and from under it's the mattress or pillow, whatever. So the small blood vessels get crushed, and the skin does not get enough blood transfusion. So it's basically the skin and the underlying tissues, they suffocate and die. So that's why we ask the people to turn within 2 hours, turn and let the tissue get some blood. So on top of that, their nutrition status, hydration, immobility of their own, extremes of age. I mean, there's a condition called dermatoporosis. The skin is actually really old and it's very thin and friable. So, and sensory impairment, they're going to feel pain. So, other chronic acute or terminal illnesses, vascular disease, mental health status, all those things matter on top of our original positive factor. So those are the intrinsic factors. The extrinsic factors can be pressure, shearing, friction, moisture. So moisture actually management of external moisture. Dr. Hillary discussed our back. So medications, all that. just remember these pressure points. So each and every lie, even seated position, has its own pressure points, which can give rise to pressure ulcer. Even the shoulders, which you can, if you can see in this right lower corner, the seated position, even the shoulders can get affected. And the head, when the patient is on the upright position in the bed, so just remember these points. So this is where these are the points that you have to check every day. Not you, basically you have to advise the nurses to check or the caretakers to check. So this is this is for institutionalized patients. So basically we'll just have a look at the topics. What to do is when the patient is you're seeing a patient, you have to do a risk assessment, and then you have to do a skin assessment. Then you go on for advising skin care. So what do you do basically? You have to advise on keeping it clean. Just when cleaning, don't rub very roughly, and they should use a moisturizer cream. And for say axilla, neck, and the other creases, and the groin, they can use powder like what we did to the toe webs. So nutritional management, especially they should be given good bit of proteins, at least 1 egg per day, and so they can have nutritional goals, daily goals that has to be achieved, and well hydrated as well. And activity management is another aspect. That's where we advise every 2 hours to change the position and all that. So what not to do not position at 90-degree angles, do not position directly on areas of redness, do not position directly on medical devices. That you have to remember. And moisture and continuous management, we actually discussed about one of that. Sometimes you may go without using diapers. I think Professor Samadhi can give some insight on this, how to manage a patient who's bedridden and with poor continence. Little bit any insight, Professor Samadhi, are you there? Professor Samadhi, Professor Samadhi has a lot of experience in managing this kind of patients.
He
Okay.
is there, he is muted.
Any insight? Okay, let's ask him later then. So support surfaces, again, you have to think about it. So there are various kinds of support surfaces. You can even do bedside things, make stuff, with pillows and all that. So this is another thing. The same thing. Graph. So not going to go into detail in that. So anyway, so there are only 3 things to do. You have to advise your nurses or caretakers to do only 3 things. Look for factors that will put the patient into risk categories. Look every day. Look for development of or at least look at the risky places, the pressure points that I showed you, and look for development or say redness or whatever. Catch it at the earliest possible stage. And if you catch one, look for what you can do. And there should be a 4th look to prevent any other from happening. So this is another, there's a lecture on wound prevention. I'll put that also into the chat. Just try to have a look at it. There's a question, sir. Though we advise the patients to buy shoes, they often show reluctance in buying the shoes. Since if the price of a patient do come with diabetic ulcer in the store, can we offer putting an extra small worn out slipper into the slippers? Yeah. To answer the question, it is 559. Candidate number 559. Definitely now the problem with the so-called diabetic shoes in the market is that they are highly priced. Originally, they should the agreement was to give it free, not free. I mean, give it not to make it a big business, because actually I was one of the people who designed it. I mean, basically, those are my designs that you get as Nirogi shoe and Beta shoe and all. So hope you can still see the slides. Can you see the slides?
Yes, we can see it.
Okay. So now that was a Nirogi was a project from DSI and SLM and Nirogi project. So we came in free, then they accept the proposal to give the shoes at mostly at the cost like 2,500 rupees. Then again they took off the designs about at the stage of prototype 3. They took it out and then formed another company called Beta. So that's then they priced it at a premium. I think 10,500. Now it's around 11,000 or 12,000 rupees. So that's why this problem. But anyway, you don't need. You don't need this 12,000 rupees shoes. You can use a flat sandal, and use, as you said, you can use pieces of rubber slippers attached to that to put a metatarsal bar, maybe input elevation, the arch support and all that. That can be done at home. I mean, I have a series of patients who have actually done it at home. So they just have to attach that insole, that piece of rubber. That we can mark them. Mark can tell them what to do. So probably they might not get it in the first instance, but eventually they will get there. So it's painstaking process of doing it over and over again, but it's still very cheap. Once they have got the proper design, they can actually sew it onto that cheaper shoe. So for about 3 months they'll be okay. Then after about 3 months they have to do it again. So I think it's still cheaper than buying those very expensive shoes. So you don't need those expensive shoes. Just get a flat sandal with at least 3 straps. Also, the straps should be adjustable, and you can lengthen the straps as well. I mean, you can attach more Velcro so that your dressing also can be accommodated into the shoe. Get what I mean? So that's all I wanted to talk about. And thank you very much for the time. Thank you very much for listening. Any other questions? Have you all learned beds of prevention and all that earlier?
We have managed in a ward setup, sir.
Yeah. So has anybody done a lecture or what to look for and all that, and the where to look for and all that?
No, sir, not really, sir. Not as concise as this one, sir.
Okay, during med school. So yeah.
Now you can
Uh,
ask questions.
Dear Dr. Tusita, I want to ask about normal talcs. Is it okay to use for the groins and the toenail inwebs?
Yeah, just talc is fine. Talc is fine until you don't get it into your nostrils. I mean, some people say not to use talc because it can give rise to various lung complications and all. But that I mean, food is probably not a problem. That's what we do actually. What we ask is to put this talc.
How about the air mattresses and the mattresses which will reduce the pressure points?
Yeah, air mattress is a must. So that's the support surface management. You see a bed sore or redness or whatever, just start. I mean, you don't have to see redness or whatever. The initial assessment. That's why this assessment thing is there. So you assess, and if the patient fits to a risk category, definitely immediately put out air mattress. And air mattresses are better than water mattresses and less cumbersome as well. The only thing about the air mattress is that you have to set it up properly and you have to check. You have to check yourself. Don't rely on anyone else. If the patient is yours, you check yourself whether it works, whether whether one set goes down, one set comes up, and when the patient is put on it, whether the patient is actually on the balloon. Sometimes these some of the caretakers, they reduce the pressure. So actually, even if the air mattress is working, the patient's body is actually hitting the bed. And when they put the air mattress, they actually take out that smaller mattress as well. So the patient is basically lying on iron.
Yeah, I totally agree with Dr. Tusita. Very correctly, he mentioned the putting up air mattresses. Actually, you have to check if the patient is yours. You have to check. I have quite a lot of experience now. Now, in this moment, we have a patient with chronic liver disease, and is in terminal phase. Absolutely what Dr. Tusisa had said, the caregiver has reduced the pressure things, and it's now the patient is lying on a normal bed. Now he developed a bad bed sore. And the other case, we have a chronic renal disease patient. He admitted with 8 bed sores, pressure points, and we managed with, now we are managing with putting a proper air mattresses and the other stuff. So now I'm quite happy, and those things are getting better. So the air mattress, first thing is you must know how it operates by yourself, and you have to check each and every time when you visit patient during your ward round. You have to check. Otherwise, it's just a matter of putting air mattress. Nurses will tell, yes, air mattress is lying on a air mattress, but nothing will happen. So I agree with Dr. Tusita.
Thank you, Professor Samadhi. One other thing is that air mattresses are very fragile things. When you move the patient, and about one or 2 months down the line, you might get a puncture. So that also has to be looked. Because now the caretaker might not know, because there will be some inflation, and the machine or pump is also working. So you can notice that when you enter the room, the pump is always working. Pump should not be working always. It should only work. That's so. Probably some of the machines do, some of the machines don't. No.
Yeah. But now there are new machines where it works, time to time, and
Yeah.
and you very correctly mentioned. So it's very fragile, and because now the connectivity is not that good. So most of the time you have to check for yourself. If a patient is, if you think this patient might get especially patients with diabetics and paraplegics, difficult to move. Now there are many gadgets where you can nicely, move your patient side to side and all kind of things. Now there are many gadgets in the field, not like good old days.
Yeah. There's a question, very interesting question. What is the recommended drug if there is there's initial period of bed sore? Yeah. The drug of choice is offloading. Nothing else. You can actually you can give some. You can put some Vaseline and or anything else also, just to keep it moisturized. But the drug of choice is, if you call it drug of choice, there's no drug now per se in any drug that is in a pharmacopoeia is going to help, other than nutrition, hydration, moisture balance, and offloading. Offloading is the mainstay.
Any more questions?
What are the benefits of air mattresses over water mattress? One thing is the control and the alternating action. If you have seen a air mattress, you might understand. So one set of balloons come up while the other one goes. So the pressure points are changed. About 10 to 15 minutes, all the pressure points are changed. So even if the patient's skin is so fragile that the pressure from the mattress, air mattress, can give rise to a pressure ulcer, that also will be prevented. So water mattresses are not as such, as far as I know, and pressure can be easily controlled and much less cumbersome. And less
Practicality, yeah,
less weight
practicality.
also.
And you have mentioned about the nutrition. It is very, very important when we are talking about wound healing and wound care. Nutrition of the patient also very important, particularly the palliative patients where they are having multiple diagnoses and most of them are, refusing the food. But as a physician, as a clinician, you must know how to give a balanced diet to a particular patient. So there are many ways. So the College of Palliative Medicine, we have published a nice booklet on nutrition. Dr. Renuka Jayat is the consultant nutritionist. She wrote that book and it's very nice. So much of practical things included, and with the wound management, you must think about the good nutrition also for the patient. This is again a very important thing, as Dr. Tusitha mentioned.
Yeah, thank you, Professor. And there's another booklet about bed sore prevention as well. So you can get those if you join the college or if you come to SLMA. And I think the copies are still not available. Madam, are they available?
Actually, now they can take free 6
Oh, they-
booklet on different aspects. We are having the annual academic sessions on
Sessions. Yeah.
fifth. Yes, fifth. Fourth is the inauguration. Fifth is the annual academic sessions. There are various plenary speakers as well as then symposium on diabetic management and several evidence-based oral presentations. It will be held in Hilton Residencies on 5th. So we will update you in the your wound care WhatsApp group in future. So then we kindly request you to come for the session.
So they can get
Any
the
other-
booklets
Yes,
free.
Yeah,
we
yeah.
are giving
That-
free booklets on for
Yeah.
the session
Right.
people. So then, any other questions you can ask from Dr. Tusitha? Right. So I have few messages for you. Actually, you all paid for this course. I kindly request you to not to share this link with others. It is really unfair for those who have paid. And also, if you can't register, rename your with your registration number, please put into the WhatsApp group before joining, because we are going to, usually we start 8:30 p.m. and half an hour before starting the session. So then you have enough time, you can communicate through WhatsApp group, we will change it. So there are sometimes people who don't know do that. Then there are some problems few people they face because they automatically sometimes there are some internet interruptions. So then there is a message 582, then Chitira, he has told he's not added to the WhatsApp group. We will do
Okay.
that.
Okay, madam. I'll add that.
Yeah,
604 as well.
Okay.
Instead of
604.
better
Yeah,
to take a
Sure.
screenshot or something.
Yeah.
Otherwise.
I'll
So
do.
then you have email actually. If you not added, please send an email. We will do that immediately. So then other thing is actually to the last week as well as the today we have removed few people because they have not registered and they have entered into these things because sometime you may actually you paid and you have a registration number. You are in the waiting list. So then it will be really unfair for you because you have to follow the course. Please, if you can't, if you don't know this, how to rename, please send an WhatsApp message. So then we have completed 2 days. So a few more days. Tusita, I would like to kindly request you to within a few minutes can you update the assignment again because now they have more knowledge, so then they can get more inputs for their assignments. Over to you, Tusita.
Yeah, madam. Yeah, just a quick one. I mean, we discussed
Yeah.
the assignment last time.
Yeah.
So it has to be, I think we have shared the assignment format. So just fill in the blanks in the format and go from each topic to topic, just again fill in the blanks and use this knowledge. Use what we have taught, nothing else. I mean, if you are going to read and all that and prefer a lot of books, right, to do that, it's okay, good. So at least the least cutoff is this, what we have taught, what we have discussed. So now a preventive aspect must be included in the management. That is the basic key message. Plus the continuous management and all that, that should be incorporated. If your case is such, you should discuss all that. What Dr. Hillary has said, he discussed a lot of technical stuff. So you can go into a little bit of details on that if your patient is such. So now next week we will be having the new lecture for today, the wound
Dr. Tushan's
biology.
lecture.
Yeah. Plus Dr. Tushan's lecture, it might take a little bit longer than 11 o'clock to finish. So both are very important lectures. Now. So tell everybody to be there on next Tuesday, and those things should come in your. There are certain topics that those things should be incorporated. Those lectures, those are the core of this whole thing. If you miss those lectures, then that's basically, I mean, you can learn this anything from the something like even YouTube. Say you should get that. Definitely, you should get that. I mean, I'm sure the discussion here is way more than that, but. Something. Yeah. So anyway, so we want you all to listen, grasp the knowledge, and plus you have to diverge it back into assignment in your own words, So that's what we actually expect. Now it's not a big thing. We have not actually put even a word limit or word count, but just be decent enough to put out a decent amount of words. So that's it. And yeah, over to you, madam.
Yeah, nothing to add much. Actually, Dr. Tusita Kahaduwa, thank you so much for having a very important discussions today. Thank you very much for everybody. Now 11:13, you are still awake and joining with us. Thank you so much. We will meet you again during next week. So I will upload the assignment format. There is a one request. I will do that. So thank you so much. Good night. Have a nice week.
Thank you very much. Thank you.
Good night.
Good night all.
Good night.